Thank you so much, Fyodor, for inviting me to this conference. It's been super exciting to engage in this discussion. My lab is in the Department of Environmental Health at the Harvard Chan School of Public Health. So what I'm bringing to this conversation is my clinical perspective. I do not have any research or publications in genome editing. I do not genome edit, but I do talk to patients about their genetic history as well as potential treatment options. And so in this very quick talk, because I want to hear from our next speaker as well, I'm going to share a couple of my considerations and perspectives from my patients. Really briefly, there's about 7.7 billion people on the earth. That's shown over here. There is a growth rate, general decline over time, and right now we're hovering at about a 1.08 growth rate. This is interestingly just juxtaposed to an overall decline in global sperm total counts, and that's what's shown right here as well. When I did a kind of back of the envelope calculation, there's about 1.8 billion females of reproductive age on the planet. And the reason why I did that was for a whole nother kind of experiment and process of could we get representation from the global world's women's population in women's health studies. And I think it's really challenging. But I also show this slide as a link to other lectures today and the interconnected ecosystem. So this is a slide showing the various stages of oocyte development, and all of the acronyms are environmental endocrine disruptors that affect every stage of oocyte development. And some of these are pesticides. And so when I hear about this conversation from the plant biologists, I am actually hopeful that maybe some of the endocrine disruptors that are on, that we know to either affect oogenesis or human fertility will actually be reduced in production and use, like, for example, pesticides like DDT and its metabolite DDE. Bringing it to human IVF, I added a couple slides because Fyodor wanted me to, and I cut some other ones. But in 1944, the American Society of Reproductive Medicine was created when a few individuals met in Chicago. Now it is one of our major societies. It's in all 50 states, and there are international members in 100 countries. The first IVF baby was born in 1978, Louise Brown. She's shown in this picture here. Over the next several decades, there was a lot of innovation in human IVF. A lot of that was unregulated. I'll talk about what regulation does exist. In the 1980s, there was gamete intrafallopian transfer, where egg and sperm would be injected into the fallopian tube and allowed to fertilize on its own. There was ICSI, intracytoplasmic sperm injection, where similar to what you've seen in videos of how the CRISPR technology is introduced into the zygote, this is the same exact way a sperm with a broken tail is introduced into the cytoplasm of a human oocyte. There were innovations in cryopreservation, and much of that was done without oversight. But a lot of clinics would learn about it and then act upon it, sometimes within days or weeks, and collect data on their own patient populations. In the 1990s, there were innovations in culture media, optimizing embryo development within either the first 3 days until day 3, when the embryo was an 8-cell stage embryo, and generally transfers were occurring at day 8. There was innovation in ambient air quality within the lab in the 1990s and through the 2000s. Assisted hatching, where a hole would be made in the zona pellucida, either with acid tyroids historically or now with laser. Blastomere biopsy, an entire blastomere on day 3 would be removed through a hole in the zona pellucida for testing using FISH, fluorescence in situ hybridization. And then in the 2000s, other things were innovated, many with oversight and IRB, Institutional Review Board oversight, vitrification, trophectoderm biopsy, the use and application of next-generation sequencing of the embryo, video-assisted morphological assessment, and now you can even culture embryos in the vagina and transfer them back into the uterus, which is considered a low-cost intervention for in vitro fertilization techniques. Briefly, the regulatory oversight of IVF includes the Fertility Clinic Success Rate and Certification Act of 1992. This mandated reporting of clinical success rates, and I'll go to the website where everyone can access to look at national summary data. And this also included oversight of the IVF lab, and the College of American Pathology and the Joint Commission on Accreditation of Healthcare Organizations, JCAHO, stepped in. So IVF labs are visited and audited regularly, and if they are at risk for poor success rates or substandard techniques, there are interventions to facilitate maintaining basic standards. I'm not a regulatory expert, and I'm not involved with regulation within my lab, but we are required to report upon our IVF outcomes, including live birth, week of gestation at birth, and other factors around the IVF, including pre-implantation genetic testing use. In terms of the FDA, there is oversight for donor gametes, donor eggs, and sperm, including oversight of screening, storage, and protocols. And right now, there is no allowable way to do the experiments that we've seen by Dr. Nia Khan that I'm aware of. I just bring this up because the American Society of Reproductive Medicine does publish committee opinions and ethics guidelines, and this is their guideline on defining experimental procedures. The first one was published in 2009 and then revised in 2013, and I just put the first essentially paragraph here. Procedures, including test treatments or other interventions for the diagnosis or treatment of infertility, will be considered experimental or investigational until the published medical evidence regarding these risks, benefits, and overall safety and efficacy is sufficient to regard them as established medical practice. So there's a lot of things that haven't even made it to this level within my field of medicine, but it is something that we aspire to. I'm going to anchor the rest of our conversation in a patient story, which happened last week, and I've changed a lot of the features so that it's obviously non-identifiable. But a young woman comes into my practice, 27-year-old. She's never been pregnant, G0. She presents for elective oocyte cryopreservation. She has a past medical history of anxiety. Her body mass index is 35 kilograms over meter squared. She has regular periods. She doesn't smoke. She drinks over 7 servings of alcohol per week. No illicit drug use noted. Her family history was notable. Her paternal grandfather was affected by myotonic muscular dystrophy. Her father and his siblings are affected. All of her father's siblings have died in early adulthood after reproducing, but not like in their 40s and 50s, due to myotonic muscular dystrophy related illnesses. The patient's sister has MD diagnosed by symptoms and genetic testing. She has not undergone any genetic testing. She did present for genetic counseling, and she has not exhibited any symptoms of MD, which include temporal wasting, a hand posture that's fixed, spasticity, and inability of the muscles to relax. And the disease goes inwards, affecting muscles of the heart, digestive tract, diaphragm, and any other organ system that has muscular tissue. So I just put this in here because I think the patient-doctor relationship is at the center of innovation in IVF, as well as some of the therapies that may or may not occur with the innovation that we have heard about during this conference. She was concerned about potentially affected oocytes, but she said to me very casually that when she's ready to use these oocytes, technology to extract the defective piece will be available. And so her indication for gamete genome editing is that the carrier state of a potentially life expectancy reducing disease. So she did not want to transmit a potentially life altering disease that would express itself later on in life, in adulthood. And it's interesting what some people feel that their personal threshold is. So I want to juxtapose this personal threshold with everything else we've talked about today. One of the critical issues is that genetic diagnosis of the parent is required for gamete genome editing. I'm not going to talk about whether or not I think it should happen or what the indications are. I think we're really far from it. I know people are doing it with relative aspects of success. But if you look at across the lifespan, you can do genetic diagnosis or screening in the preconceptional window. So you're able to identify your concerned gene target before conception. If this happens, then maybe gamete editing is a possibility. For the people that undergo IVF and get pre-implantation genetic testing for either aneuploidy screening or diagnosis for a monogenic or structural rearrangement, that happens at the blastocyst, and we heard it's about 100 to 300 cells. And so what can potentially happen is that there are no suitable embryos for transfer. Would we consider gamete genome editing here? Possibly, but it would never happen in this cycle. It would have to happen in the next cycle. So we're exposing a couple or a woman to a second cycle of IVF. What is on my wish list is advances in somatic gene therapy, so diseases that are diagnosed in the perinatal, early childhood, adolescent, and adulthood window could have a potential of being treated. We'll get back to that in a moment. So in this summary paper by Viati and his colleagues in the CRISPR journal, they went through what happens at the blastocyst stage. A biopsy occurs, there's a set of embryos generated, all of these get biopsied, and you transfer the normals into the patient. So if when you undergo PGT, you are able to select a non-affected, non-carrier, or a variety of discussions can happen in the setting of indeterminate embryos. This path to using genome germline editing can only happen in the next cycle once no normals has come to pass. I turn to another ethics committee opinion of the American Society of Reproductive Medicine for the use of pre-implantation genetic testing for monogenic defects in order to frame this conversation. And basically, they express that testing for diseases for adult onset conditions is ethically permissible for a range of conditions, including when the condition is serious and no safe, effective interventions are available. So I thought that was an interesting introduction. And of course, all we want to have is a healthy baby with the potential to determine its own future unhindered by major preventable disease. So let's say we go to get a PGT result. You can find this online. Almost all the data in my slide set is you can find online. So there are multiple companies. They often buy each other. This is from Invitae. This is an example report. 4 embryos were biopsied. Here they are listed. You can have the chromosome result. Sometimes the output is a little bit different. You get the gender. You get what they think is abnormal, normal. What's not on here is they're often mosaic, indeterminate, different outcomes, and that requires a lot more discussion on what to do in that setting. So to talk a little bit about current genetic screening approaches, so we're not biopsying the embryo. We're talking to the couple. We're talking to the individual who wants to store gametes. There is some basic genetic screening recommended by the American College of OBGYN and American Society of Human Genetics, and that's cystic fibrosis, spinal muscular atrophy, and a hemoglobin electrophoresis to assess for sickle and beta thalassemia. What's commonly happening now is there are a lot of commercially available expanded carrier screenings, and sometimes you can reflex test the partner if anything turns positive. If this happens, there's an automatic discussion and a visit to the genetic counselor to discuss heritability and severity of the trait. Oftentimes now you get an automatic readout of what the trait is, and all of this information comes when you order the test and get the result from these companies. And so I also want to mention for individuals who are either using donor gametes or donating their gametes, expanded carrier screening is going into effect for a majority of these individuals, and I recommend that anyone using a donor gamete is screened on the same exact platform that their donor was screened on, because there are differences in screening platforms. Here's an example of how this is marketed to the population. Starting a family, why don't you start with an expanded carrier screen? Regardless of, other considerations. The way these companies have framed how to pick diseases on their carrier screen include the severity of the disease. Is it actionable? Can you decide to not transfer an embryo? What's the prevalence of the disease? And how sensitive is the technology to accurately detect the disease, false negatives, false positives? Here's an example of expanded carrier screening that I use in my clinic right now. There's approximately 176 genes that are tested. This patient who came in with a concern for MMD, I looked it up. There's 2 genes, DMPK, ZNF, F9, but they're not on this list, so this would not have helped her. We couldn't have predicted this from this. And it's just to say that, ACOG recommends 2. It's right here and right here. The ACGME recommends the same handful. And then if you get into at-risk populations, those recommendations are different. So if you get a risk screen, this is the report that happens in the setting that the female partner is positive and the male partner is positive. It says high reproductive risk. This is very scary. What is that risk? It's 1 in 4. So 25% chance of passing on an autosomal recessive. Of course, we know that many times, and I don't have a percent for you because it's hard to actually get this data, there are no gametes to transfer because they're all affected. I can envision a time where, due to machine learning and big data, there's predictions on the likelihood of 0 normal embryos for transfer in this kind of setting. And I think maybe we're 5 to 10 years away from that. And what do you do with that kind of information? Do you go to a donor gamete? Do you try to innovate around germline editing when you don't know what the risks are? So these are just anchoring parameters. In 2016, and anyone here can go to SART.org. It's a Society for Assisted Reproductive Technology. They collect all of the outcomes data from IVF in the U.S. There are about 450 SART member clinics. You don't have to be a SART member to do IVF in the United States, and if you're not, you have to report your data to the CDC. But it is a benchmark of quality to be a SART member. In 2016, there were 200,000 cycles, 240,000 cycles. And you can look at all-comer national outcome data. You can stratify this data by clinic. I just put up this slide that Professor Dana had mentioned yesterday about in vitro fertilization. It's not exactly scrub-a-dub. A woman doesn't just go in, take some injections, and you get a huge amount of eggs out. These patients are often suffering. They're in pain. They've had infertility. They've had family histories with the burden of certain genetic diseases. Sometimes you don't get eggs. Sometimes you can't dose them appropriately. Sometimes they hyperstimulate. And so I think that we're getting close to very safe IVF, but it's still, when we're thinking of germline editing, it really is a woman's health issue because you have to get the oocytes, and it's harder to get oocytes than it is to get sperm because of the biology. So among those 240,000 women, couples going through cycles, some of those were individuals for embryo banking. There were a number of people who did expanded carrier screening. I don't have the full number, but if you want to think about PGT cycles, it was 75,600 cycles. About 31% of people undergoing cycles in the U.S. were having PGT, and that includes aneuploidy screening and for genetic diagnosis. Some of those people were banking their embryos. 0 were banking their eggs for future fertility preservation. And it's just, it's interesting. You wouldn't do PGT if you're banking your egg because PGT means you have a trophectoderm biopsy. And this just shows you rates over time. In the age less than 35 group, the chance of conception with a singleton live birth at cycle start is about 40. It goes down to 8% at 42. This is still higher because of the way the data is cut. But what I quote to my patients, it's about 4% chance of pregnancy at the age of 42, and age is a major determining factor in success. So then we have the number of cycles for aneuploidy screening, the number of cycles for genetic diagnosis, and then you have the number of cycles with 0 to transfer due to a gene disorder, with the caveat that sometimes people are transferring indeterminate embryos because they would rather take the risk of an abnormal potential genome than not have a baby. And then here we have somewhere the indications for genome editing. I just put here general costs, average costs. In some states, things are mandated to be covered. Often, if you're undergoing PGT, sometimes the embryo biopsy is not covered. Cryosurge may or may not be covered. So it's approximately $20,000 to get to a no embryos for transfer, plus the cost of the next cycle, plus the cost of germline editing. So in summary, I think that there are some considerations for germline editing, and one of them is that IVF with ICSI, where the sperm is injected into the egg, if germline editing is happening at that time, There are unknown risks, and the couple has an age-related risk of miscarriage. So you could do all of this and still miscarry that embryo. And that has to be discussed because there are so many expectations when a couple comes in, or a woman, for freezing her eggs for future fertility. The chances can be very slim in certain categories. The considerations include discussion of alternatives, including adoption and child-free living, that thought of no normal embryos for transfer after repetitive attempts, because you can always go through again and try to find a normal embryo. I just put in these considerations in terms of thresholds. If both individuals are carriers, the likelihood of an infected is at least X%. I can imagine thinking about threshold where this might be indicated. And the chance for no embryos is high, and there are no alternatives for serious diseases, and this is subject to interpretation. And would you restrict to causative genes? And how would you do expansion repeats like Fragile X, or MMD seems to be an expansion repeat in the setting of no alternatives? So I think it's also critical to have a registry of all humans born to this technique with long-term follow-up, as was mentioned before by the FDA. And I think this would be really important even for somatic therapy, because they may likely need germline editing if their illness impacts on their fertility. The questions I ask myself are, do we really need germline editing if somatic therapies can reduce or eliminate disease like sickle cell? What about non-propagation of carrier states when you do PGT, transferring non-carrier states? There might be other indications for genome editing that would facilitate other types of therapies at the level of the mitochondria. And of course, we've talked about this too: efficacy, safety, risk, benefit, alternatives, informed consent. There are unrealistic expectations when patients come in, but sometimes that drives innovation. And a lot of people have been talking about in vitro gametogenesis bypassing this whole process. Just to give you a brief example, and you could Google all of our consent forms. This was from my practice at Boston IVF. There's a 24-page treatment booklet. There's 6 pages of signed consent for IVF. There's reconsent every 3 to 6 months, depending on what's going on. And you have to have a disposition if the partners die on what happens to your embryos. So this is a big process. I'm curious to know from Dr. Neocon if those egg and sperm donors are aware that their gametes may be going to human research at the level of what you're doing. But here in the clinic, patients can choose one of the following options regarding your discarded sperm, unfertilized eggs, or embryos, and it's like yes or no. And so to get it down to a binary answer requires a lot of discussion. And in summary, I think that germline editing seems to be like a distant plan B when prevention with PGT has not sufficed. And I really do think there remains a role with the limitations of PGT, but the goal would be selecting for healthy, unaffected embryos. And there isn't a lot of oversight with what that means in this country, and couples are really deciding what that means for them and their families. A lot of special cases will arise potentially in considering the potential of CRISPR in the germline. I can send you any of these references that you want, but there's a lot of practice guidelines and ethics committee opinions on these items to guide the American IVF community. Just wanted to thank my lab, who's doing a lot of work for me at home while I'm here. And I really wanted to thank Francois Bayless and Amy Koski, who really engaged with me at ASRM 2019 in October to discuss these topics. My embryology lab director, Charles Borman, my current nurse, Carroll, Meyer, who scoured through, the panel screenings to figure out with me whether or not a patient would benefit from these tests, and other team members who were involved with comparing an individual's report against a donor's report and thinking whether or not we should switch a whole donor when that might have been their ideal sperm donor. But, unfortunately, that genomic screening doesn't work out. There are some futurists that discuss in vitro gametogenesis, and it's interesting to consider that as another thing. And thank you, Fyodor, for inviting me.